I'm going to now, if I may, introduce our next speakers, and we're going to have two speakers who's going to talk around physiotherapy and speech rehabilitation following head and neck cancer. And this is really true leaders in the field, Susan Coulson and Emma Charders. Emma graduated with a Bachelor of Applied Science in Speech Pathology in 2008 from the University of Sydney and has spent 10 years working in tertiary referral hospitals in Sydney. She has specialized in communication and swallowing disorders in adults in acute rehabilitation and community settings. She has a special interest in head and neck cancer. We should congratulate Emma because she's just submitted her PhD thesis through the University of Sydney and is passionate about seeking to integrate research into clinical practice to ensure up-to-date and patient-centered care. Dr. Coulson is a clinical and academic physiotherapist whose main area of interest is in assessment and treatment of facial nerve disorders. So this flows on very, very well from Dr. Lowe's expertise. Her doctoral and master's research were at the University of Sydney, where she currently holds an academic position. For about 30 years, her clinical and research work has focused on assessment and treatment of facial nerve disorders, including using 3D motion analysis, reliability of grading systems, telemedicine reviews, and interventional studies. Susan is a founding member of the Sydney Facial Nerve Clinic, and she is a board of directors member of the Sir Charles Bell Society, an international group of facial nerve practitioners. So over to you, Susan and Emma.
Thank you, Patrick. Tonight, Emma and I are going to be talking about physiotherapy and speech therapy, and thank you for that warm welcome, Patrick. I'm a physiotherapist and Emma is a speech therapist. And the first thing that I'm going to do is tell you a little bit about, or we're going to do is tell you a little bit about ourselves. But before we do that, I'm going to tell you a little bit about where we work. And that's in two places. One's at the University of Sydney. As you can see, my background is tonight in the quadrangle. It's also a pleasure to work at times in the Chris O'Brien Lifehouse, which is really where you mainly situate yourself, Emma, I think.
That's correct. Yes. No, my main place of employment is with Lifehouse. All
right. And that's a really beautiful purpose-built building. It specifically deals with cancer care, Emma.
Yes, that's correct. It's been there since about 2014 or 2012 for outpatients, and then a couple of years later they opened to inpatients, and it's one of the largest head and neck referral hospitals in all of New South Wales, if not Australia.
Thank you. So today we're going to talk about what you do, Emma, as a role as a speech pathologist, and I'm going to talk about what physiotherapists do with head and neck cancer. And we're going to both talk about the kinds of assessments that we do and why we do those assessments. And then we're going to talk about treatment. And you're going to talk about the main principles that underlie treatment and what further support mechanisms are in place for people who have got head and neck cancer. So Emma, what do speech pathologists do with head and neck cancer to really ensure that people live as well as they possibly can with this disorder?
Thank you. Yeah. So if you're on this webinar, you probably know that a speech pathologist is part of the multidisciplinary team for cancer treatment. And so we look at assessing and then managing swallowing, and as well as communication and speaking problems. So the two things which really are critical for living well after a cancer diagnosis and treatment for cancer are being able to swallow easily. So being able to go out for a coffee, being able to sit down for a Christmas dinner with the family. And secondly, to be able to speak clearly, but also confidently for work, but also for social and integrating with community and just chatting to your neighbour next door. So speech and swallowing problems are really common to arise after treatment for head and neck cancer, and because it involves, head and neck cancer and swallowing involves parts of the head and neck that are often a part of the cancer, either taken out from surgery or either irradiated during radiotherapy. Sometimes the problems sort of with speech and swallowing arise early, and sometimes they arise later with life, which can be a bit of a surprise for people who potentially did reasonably well within treatment, but then later on got surprised by some problems arising later.
Thanks, Emma. And I'm a physiotherapist, and we do all sorts of things, as Emma does as well. We looked at facial expression and facial symmetry and the way people appear in the world. We also look at helping people with eye closure or when they have incomplete eye closure, and pain and discomfort around the head, neck and shoulder area. Sometimes after head and neck cancer, they have facial problems. They have spasm in different parts of their face, or perhaps muscle tightness. And that can be associated with the way that the nerve grows back after it's been injured. And it can also be associated with perhaps scar tissue and tight scar tissue. Of course, it's not just the head and neck in this region, it's the shoulders, it's the cervical, the thoracic spine areas as well. And as physios, we treat the musculoskeletal components of those. And we also treat jaw problems, as speech therapists do as well. So tight jaws, spasm around the jaw, people not being able to open their mouths as well as they'd like to be able to get enough food, enough nutrition in. We look at cervicogenic headaches and dizziness sometimes. But as well as that, we're physiotherapists, we prescribe exercise, and we look at and ask about people's general strength and conditioning. So Hubert earlier talked about the planning, and people both such as speech pathologists, such as Emma and I, are often involved in that pre-surgical planning. So we may see somebody pre-surgery, or we may see somebody for the first time after the surgery. But it's not uncommon to be involved in both aspects of their care, or both time points of their care. So when I go through this assessment slide with you, it's about things which actually both Emma and I would be asking about. We'd be asking about your history, and it's saying, you know, what's happened and when. And sometimes this feels a bit like a repetition because lots of people have asked you about this, but it's really important to help us understand what's happened to you and what your main concerns are. The thing that's bothering you the most, and we'll often spend a bit of time on trying to really deeply understand that, because what's bothering you is what we really try and focus on the goals of your care with. We look at the symmetry, we do lots of assessments around your face, the way it moves, looking at scar tissue and how pliable, how malleable that is. We look at facial movements, facial expressions, and the way the jaw moves in the different directions, how far you can open your mouth, for example. We look at your neck, your back, your shoulder movements. Probably physios would do that more. But we also look at muscle spasm around this whole head, neck and shoulder region. Some patients have dizziness associated with their cancer or their surgery, and we can do assessment and some treatment for that. But we'll ask you about that sort of thing. Emma will really more focus on speech and the swallowing and oral incompetence when you're trying to eat a meal and you lose a little bit of the food or the drink out of your mouth. We ask about lymphedema, and we may measure lymphedema around the head and the neck region. But we also ask you about whether you're getting out in the world or not, whether you're confident to go out and interact with people in a social situation, in a work situation. It tells us a little bit about how we can assist you further, and what kind of impact this is having on your quality of life and your appearance. And we also ask about your general strength and overall condition. So in the early stages of management, really, which is where this part of the slides talked about, I'll tell you a little bit about what physio does, or the areas physio works on, and sort of a little about what we do. And then Emma will talk about speech. So after a diagnosis has been made and a management program's been set, and we've taken a good history, we may be seeing you in the hospital, and that might be for chest physio. It might be getting you out of bed and early mobilisation. It might be working with the medical, the surgical, the nursing team about having wound care, making sure that that's all, if it's going to be going home with you, all well supported as well. We might be looking at that facial droop and symmetry, and not giving you exercises at times that you don't have movement on your face, but really letting you know what to expect when maybe movement returns if your facial nerve's been affected. We'll be assessing your jaw, because it's really important to have a certain range of mouth opening to enable you to get food and drink in. So we might be doing some treatment around your jaw. As I said before, dizziness, lymphedema are things that we treat, and we may send you to other people to support that treatment and care who are more specialist in those areas. And we ask questions and refer on at times to psychologists. If that's something that you're feeling you'd like to have a talk with somebody about, the things which are bothering you in terms of your appearance, confidence, your self-esteem, and we look at exercise and fatigue and the role that plays in your care. Emma, you cross over on some of those things, I know, but would you like to tell us a little bit more about the speech side of what you do?
Yeah, so as a speech pathologist, we work very closely with dietetics, whether you go down a radiation or a surgical route for your treatment for head and neck cancer. Those are the two primary modalities that we would be expecting, plus or minus a bit of chemo. But whether you're having speech or swallowing problems, we do expect those sorts of things. So early in terms of early stage management, a lot of them tend to be compensatory type of techniques, which help make life a little bit easier while you're getting through your treatment. But I suppose in the early stage of the recovery of treatment, that's when we're really going to be doing a bit of a little bit more exercise. And it is hard because while we want you to do a fair bit of, we'll give you a whole bunch of exercises and you might feel quite overwhelmed, it's really important to making sure those exercises fit within what is going to work for you. Because if you've got a whole bunch of exercises to do for perhaps the physiotherapist plus the speech pathologist, plus trying to get a whole bunch of nutrition drinks down, plus waiting for a wound care nurse or something like that, I think the really hard thing in the early stage management of head and neck cancer is that there are so many different disciplines involved, and just trying to integrate all those different recommendations in your life is really challenging. And so often what we're trying to do is working out what we can prescribe that is going to work for you and not setting you up to fail, but setting you up to have something that's achievable and that's really relevant for your care. So we hope that it's individual and it's based on you.
And I think that's something you're going to go into in a little bit more detail in a moment, isn't it? So that that prioritization and that real individual care for patients, because as you say, there's an awful lot going on. It's not just in the early stages, that's in the mid and later stages, where if we look at the slide of the things I spoke about before, it covers a lot of those things, but we're increasing the level of difficulty. We're trying to help you get stronger, fitter. If you've got lingering pain and discomfort, or maybe a limitation of range of how far you can lift your shoulder up or turn your neck, we're trying to progress that on further. So for perhaps if it's a neck limitation, so you can then look around when you're trying to reverse out the driveway, or you're really trying to use that neck to be able to move as many directions as it can. We're also looking at increasing the complexity of facial movements. I've got a great job. I teach people how to smile, how to close their eyes, how to express emotion on their face. And this is a complex range and series of things, and it requires quite a lot of thought quite often about something that you've probably never thought about until something went wrong with it. So that takes quite a bit of work and practice as well. So I not only work on the expressions, but also the spasm that sometimes happens on people's face, or sometimes you have synkinesis, which is when two parts of the face or many parts of the face move together rather than in a well-orchestrated way. And we work on separating those processes out, those movement patterns out. Both Emma and I work on those ongoing jaw problems, if there are those, and things like dizziness and appearance, confidence, self-esteem are not things which are just managed in the early stages. They're managed, of course, in the mid and later stages if needs be. Emma, how do you progress your speech treatment on in these stages?
So we'd be adding load on. So it depends on where that person is up to in their journey, but we'd be adding the complexity, just like Susan said. So we might be, if somebody is on a sort of a softer diet after having treatment, if they've been given clearance by their doctor, we're teaching people to be able to use their entire mouth to be able to chew, teaching them the different types of textures that might be suitable for their point of recovery. We'd be working out where they're up to with their speech and seeing whether there's a way that we can increase their clarity, and if they've had part of their mouth or their throat removed or, altered through radiotherapy, how we can either compensate or rehabilitate that, and making people as clear as they can be, not just in face-to-face conversation, but over the phone. We're in a world where sometimes you're wearing face masks, and that can be harder to be well understood whether you have speech problems or not. And when you don't have the benefit of all those non-verbal cues, if you're over a telehealth Zoom conference sometimes, or over the telephone, that is more challenging. So giving people cues and strategies about how to deal with different sorts of situations you might come up with in your everyday life.
Thanks, Emma. You're going to tell us a little bit about the principles. You've spoken about how care needs to be individualised at that particular time during that recovery period. There's a whole lot of principles that underlie that, but really four main ones. Would you like to take us through these, please?
Yeah, sure. So we'll go into detail for
a couple of minutes left.
Thank you.
Sure, yes.
We'll speed through. So essentially the main ideas that we're looking at are the strength and endurance of muscles. So we want to be able to add for speech pathologists, we want to add load. So we want this to be challenging for you. If it's not hard for your swallowing or your speech exercises, we need to work harder at it, because it's sort of like going to the gym. If it's not hard, you're not going to have a great deal of improvement. The second thing is specificity. So we need to choose exercises that match your goal. So if you want to work at swallowing harder, you need to actually be doing swallowing exercises. Individuality. So this needs to be specific to the particular person and what their diagnosis has been. And then we need to be able to maintain your maintain the goal, the benefits that you, or the, you know, the improvements that you might have made over a therapy protocol. You need to be making sure that you're being challenged, but in a safe way. So it's kind of like thinking that you're going to the gym. So if you started off on a 3 kilogram dumbbell on a bicep curl, you want to make sure that you're increasing the difficulty of your exercises so that you continue to make improvements. So for example, in a speech pathology situation, we might select, if you're, you know, working on some speech sounds, we'd select a level. So you can see S by itself might be super easy, you know, in a sentence or conversation is quite hard. So we would select a level to practice that's achievable, but that's challenging. And then you would hope to progress through the level of difficulty as you go through. One of the ideas that I often get people to do is read out loud, you know, reading a book out loud, record yourself, listen back to yourself. Specificity, many years ago, we used to give people exercises, you know, move your tongue around your mouth, give it a bit of a stretch, but that actually is really hard for muscles to translate moving your tongue around to actually speech and swallowing. So we want you to be practicing the sounds that are difficult and practicing them in real life situations.
And we also want you to be smiling, of course, rather than just doing these movements of your face. We want you to actually be practicing smiling in a social situation. So it's being specific to the movements, isn't it, Emma?
That's right.
The underlying principle here, because I think you also wanted to talk about overload here.
Yeah, and swallowing, I mean, we always recommend, there's just a video playing of a swallowing assessment.
No, I don't think it'll play for us this evening, but perhaps you could tell us.
No problem. There's different types of swallowing assessments that we always do before starting swallowing exercises. So there's either a video fluoroscopy, which is it was sort of an X-ray movie, or a camera down the nose, which you might be familiar with, and watching a swallow at the same time. We need to do those assessments before we do swallow therapy, but the idea once you've done that is really working quite hard, and either you can't put a weighted dumbbell on your throat, but you can increase the complexity by using harder foods or bigger volumes, and that's something that you need to be guided by a speech pathologist and your doctor, but it is something you need to work hard at. Otherwise, you tend to see a bit of a plateau. And this image that you can see there, it's just a nice idea to see the level of effort. Seeing if you're at 0, you're not going to get a lot of improvement. 10 tends to be not able to maintain. So you're wanting to work at about a 7 or an 8 when you're doing your exercises.
And that's being how hard the exercise feels for you, Emma.
That's correct.
And they've got to do homework.
That's right. If you don't do homework, often because you get fibrosis later on in treatment, which can be like a progressive stiffening of the neck and the head muscle, the head and neck muscles, which are involved in your treatment, you do need to do maintenance a lot of the time, particularly for your speech and swallowing, because they can be a tendency of the muscles to get hard, tighter over time. So doing some maintenance exercises is usually recommended.
Yeah, and you've got to maintain your smile. So it's actually using the smile at the appropriate moment in a social situation, using your face symmetrically. So of course, we have to keep maintaining that. So we manage loads of different areas, different time points. We see you before surgery in some cases. We see you immediately after surgery or radiotherapy or when you've had an injury to the face. But we also see you as an ongoing care point. We assess you. We ask what's really bothering you. We treat you. We try to make that treatment as individualised as possible. We make it task specific and part of your overall care. We work as part of that multidisciplinary team with surgeons, with other different health practitioners. And we will post this. It's got links to the further support of some of the places that you might find some interesting information. Thank you so much for listening this evening.
Thank you.
Thank you both. What really impressed me there were two things. The first, very, very briefly, how two professions are working in a multidisciplinary way to make sure the patient gets the best outcome. Second thing that really impressed me was about, and we heard it a number of times through that talk, how we were both aiming to make sure that it was about the best individualized care. It wasn't about one solution for everyone. So thank you both very much for that excellent interactive presentation.
Thank you, Patrick. Thank you, Emma.